Welcome, everyone. I am here today with a return guest and one of my classmates from way back when in our MSW program. I'm here today with Sarah Rollins, and she's going to talk to us, give us a very broad overview of EMDR, which she uses in her work. And I know a lot of people are very interested in this modality. So she's going to talk to us a little bit about what EMDR is, who would be a candidate for this, and then she'll talk a little bit about the training because it does require that you are trained in this. Not just anyone can go out into the world and do EMDR. So we will dive in just a minute, but Sarah, thank you for being with us today.
Yeah, I'm so excited. I'm glad to be back.
Yes. So some logistics. My name is Megan Mitchell. I own my own private practice, solo practice, and I see mostly children and adolescents, and it's called Brain Space Wellness here in Ann Arbor, Michigan. I also am the founder of Social Work Agents of Change, Social Work Test Prep, and obviously we are now moving into the CE space. I graduate with my DSW in 2 weeks. So yes, that is it says currently I'm a candidate, but soon it will be a graduate of SUNY Buffalo. So I'm wrapping up. I'm very, very, very happy to be wrapping that up. That has been an almost 3-year journey too. What am my clinical interests? Lots and lots of different things: play therapy, expressive arts, ADHD, executive functioning, implicit bias, multicultural supervision, lots and lots and lots of things. So yes, that's a little bit about me. And I'm going to read to you a little bit about Sarah. So Sarah also is a private practice owner, but she has a group practice. She is the owner of Embodied Wellness, a group practice specializing in online therapy for adolescents and adults. And she's also in Michigan. She does somatic experiencing, which she talked about last time. EMDR, which we're going to talk about today, which stands for eye movement desensitization and reprocessing. EMDR is much easier to say, and IFS. And she specifically focuses on trauma, PTSD, depression, and anxiety. She'll talk to us a little bit about that as we get into our EMDR conversation. Before she did her private practice, she was at U of M doing psychiatric social work, and she was, like me, a school social worker for some time. She worked also in foster care as well. She has lots of different interests as well. She talked to us about her somatic work, trauma, and very busy being a practice owner, as we were just discussing before we got on this call. So she also focuses on supporting BIPOC and LGBTQIA plus communities. So that's the background about Sarah. And I'm going to do a couple more housekeeping things, and then we're just going to jump in because we want you all to earn your CEs. Why is this topic important? EMDR is a proven, very effective evidence-based trauma treatment. And I think some people that maybe are not familiar are kind of like, what is this modality? I've heard about it. I'm not really sure. What do you mean you use bilateral stimulation? So we'll talk a little bit about that. And why it is proven effective for trauma. We're going to talk briefly about the cultural responsiveness of it and how that plays into Sarah's work with using EMDR and how she can be inclusive for all backgrounds. And EMDR is evidence-based. I'm just going to put that out there, and it's very effective. So as clinicians, we should always be seeking out modalities that are evidence-based and robust. So we're going to talk about how, if you're interested, you can learn more about EMDR. And our objectives today: participants will be able to explain EMDR therapy techniques. This is obviously not an EMDR training course. This is a very brief overview of what EMDR is and who you might refer out to or who would be qualified to do it. Participants will also be able to assess and integrate therapy approaches. So you will learn more about what EMDR is today. And then Sarah will talk a little bit about some of the EMDR misconceptions. So what are some myths people have or questions or whatnot? So we are very happy to have Sarah here. So without further ado, Sarah, welcome, welcome, welcome. It is great to have you.
Great to be here.
So let's just start off by I gave the long, EMDR acronym, but from your perspective as a clinician that utilizes EMDR, what is it? How did you get introduced to it, and how long have you been practicing it?
Yeah, so I've been practicing EMDR for maybe 3 years. So I took the training, I think time eludes me sometimes, but I think, like I said, a couple of years ago during the pandemic. So I took it all virtual. And I think that's one of the biggest misconceptions about EMDR is that you can't do it virtually. I just talked to someone on the phone today and they said, "Oh, you can do it virtually."
Yes.
And so, yes, you can take the training virtually and you can also be a client virtually. So I always say to my clients that it's just preference, that
Exactly.
um, there are um, websites that there's like a little ball that moves on the website that can help, or because really what it is bilateral stimulation, which we can talk about in a second what that means, because that's a pretty big word.
Yeah. I'm glad you said that it can be done online because I have some colleagues in my DSW program who are studying EMDR, and research shows it's just as effective online as it is in person, which is a really strong, powerful therapy if it has the same efficacy in both settings. So that's a bit, like you said, that's a big misconception, is that you have to be in person. No, it's just as effective in the online space as well.
Exactly. And what I say to people is that it might be less effective because you might feel like you can't build rapport online, but that's about the rapport building, not the efficacy of the treatment
Right.
itself.
And that's just more the pluses and minuses of online therapy in general. Nothing to do with the
Exactly.
MDR.
Exactly. Exactly.
So, you've been doing it for a couple of years now. Tell folks that are listening in about like the training, because not anyone can just you and people might hear, oh, this person dabbles in EMDR. There's actual training that you need to do. And I think it's really, we talk about this a lot, it's really important to find someone that is trained in EMDR.
Yeah, so that's something that I think is really hard in this field about what is someone who is just IF or sorry, not IFS informed, different webinar, different training on that. So what's EMDR informed or who's trained or who's certified? So EMDRIA is EMDRIA. So that's the acronym EMDRIA.org is where the official training is. So if you are a therapist or a client, that's where you want to make sure that you're getting that training or seeing a therapist who's gotten the official training through EMDRIA. Again, EMDRIA.org. So they have
That
training.
in the resources so that people can just be directed to that website.
Amazing, right? So those trainings are about the first level is about 5 to 6 days. They include 10 hours of consultation, and that's called basic training. So that means that a therapist is trained. Then they can go on to what's called certification. So for example, I'm trained and I'm in my process of certification. Certification includes CEUs, it includes another, I think, 20
Yep.
consultations, and then a lot of practice hours. So, working with a certain amount of clients, doing a certain amount of EMDR sessions. So, it's very extensive. And there's a directory on emdria.org of therapists who are certified. And in order to get the consultation hours, you have to work with a specialized consultant. You can't just work with anybody who does EMDR.
So it is a very regulated training process, right? And you do want to make sure that if you are like, you might, we always like to warn clinicians out there, if you see something like get trained in 5 hours, that's not going to be legit. So you want to make sure that you're going on the official website, you're learning more about it, and you are making sure that if this is something that you are interested in, you're getting the proper training, because you you just got to be very careful for ethical purposes and legal purposes. So what made you interested in this modality? And so you said about 3 years, and what made you take the leap to say, I want to get trained and start incorporating this?
Great question. So, as some of you know, I also do somatic experiencing. So, I started with that. And somatic experiencing is a modality that really focuses on processing trauma through body sensations, thinking about incomplete self protection responses. And I love that modality. And I will preach this till the day I die is that there is not one modality that I use. I don't see one modality as the end all be all. And so as I continue to work in my training through somatic experiencing, I realized that there were holes in that treatment modality because one size never fits all, right? Those pants don't always look the best, right? In every situation. So I realized for me and the way a lot of my clients were engaging in somatic work for a lot of the complex trauma, somatic work was really beautiful and it helped them get to a place where they felt more embodied, less dissociative, really, really present in the world. What I was noticing though is that when it came to specific events, it wasn't really as helpful as I needed, that I needed more tools. And so that was where I looked into different modalities and I was came across EMDR and I think for me using somatic work as a preparation for the EMDR processing because that's one of the misconceptions. EMDR is actually 8 phases. It is
Mm.
not just you jump into the EMDR processing. And so I can go through those 8 phases if needed, but a lot of people think EMDR is a very quick fix and then you just jump into the treatment. And for some people, it could be. It could be a couple sessions and it's um, kind of a hop, skip, and a jump, but it can be a year, 2 years that
Mm.
someone is in EMDR. It's not necessarily a short-term treatment for a lot of people.
And we'll get into discussing the 8 phases a little bit more in just a second. But so, what is EMDR? Obviously, it's 8 phases. There are certain tools that you need, which can be virtual tools, and there's physical tools. What is it, and what is the research behind it to prove that this works? It's actually
Definitely.
like people, I think there's misconceptions because they're like, what do you mean with bilateral stimulation and eye movement? Stuff comes up. So if you could explain it, that'd be great.
Yeah, of course. So EMDR, like we said, stands for eye movement desensitization and reprocessing, which is why we call it EMDR because that is one big
Yes.
mouthful. So Francine Shapiro developed this treatment when she noticed that the sense of moving back and forth helped people reprocess their trauma. So that could be eye movements like left, right, or tapping.
Okay.
Um, so it allows for the reduction and vividness of the emotions associated with traumatic memories to reduce. But one of the things that people ask is like, am I removing memories? No, right? We are never getting rid of memories. We're never questioning, did something happen or not? I'm not a detective to
Mm.
determine, did this happen or not? We're reducing how vivid the memory is, how distressing and how interfering. So those PTSD symptoms reduce. Um, so it works by helping the brain process trauma memories and allow the normal healing process to resume. So basically, trauma, what can happen when we have a traumatic memory or experience is that it feels like we're kind of frozen in time and we can't kind of resolve it in the normal way. So, what EMDR helps us do is kind of regulate and get out of that fight, flight, and freeze so we can kind of come back to regulation. Um, so, um, would it be helpful if I go briefly through the 8 phases?
That would be great. Because I think it's, 8 phases is a lot of phases. So if you could like describe what that is and maybe just a quick synopsis of what that phase might look like.
For sure. Yep. So the first phase is history taking and treatment planning. So a lot of times when people come in, they say, this looks like every other treatment I've ever done. Yes, right? So you
Collect
need to,
information.
yeah, right. You need to gather information. You need to build foundation of trust with your therapist. You need to design a treatment plan. So the treatment plan will look a little different, but again, you need to build trust with your therapist. There needs to be a sense of safety. Their therapist needs to understand your history. All that is phase one. For some people, it takes less time. For others, it takes more. It just depends on how complex the trauma, how old you are, right? If you're 20, it's going to be different than if you're 40, right? Like,
Comfortability with therapy in general, I'm
yeah.
sure. Right.
Yep. The second phase is preparation. So the therapist is going to educate you on the EMDR process. You're going to develop an open dialogue to create comfortability in the environment. And think about this as like you're putting your gear on to start your flight, right? So we're putting your buoy on, we're putting your goggles on, right? We're putting all this gear on so when you go into the trauma processing, you have you have you have all your tools on in a tool belt because we don't want to push you into the pool without your goggles and your flippers on, all that kind of stuff. So this is where I like to use other techniques like somatic experiencing, IFS, and in the EMDR training, they give you a lot of tools too.
And I'm guessing this is also a stage where this depends on where people are at for how long they'll be in this stage for.
Correct. And it's not linear. So we
Mm.
come here and then we can also go into the next stage and we might need to go back to preparation.
Okay.
Yeah. So the next stage is assessment. So we're going to identify the focus of our healing and we're going to find a target event. So, EMDR can also be used for phobias. It can be used for OCD. It can be used for addiction. So that's one of the cool things about EMDR. It's not just trauma.
Right.
There's obviously other um, presenting problems it can be used for, but we're going to really identify the emotions, beliefs, sensations, images linked to the event here. In phase 4, this is where we think of what traditional EMDR is. It's the desensitization. It's being guided by your therapist in the bilateral stimulation. So in the eye movements, in the tapping, where you're going to actually reprocess the target memory until it's no longer distressing. And again, it might take a session, it might take 2 sessions, it might take 10 sessions. And I'm
And
making up 10. Yeah.
is that in this phase where people are rating how distressing that is to them? I'm somewhat familiar with it.
Yes. Yes.
Okay.
Yep. Yep. We call it SUD, subjective unit of distress.
Yeah. And you might use SUDS in other way. Like you don't have to just use the SUDS um tool just in EMDR. Like I have for kids a thermometer that is a SUDS tool. So it is used in EMDR, but it can be used outside as well.
Yeah, and I think that's one of the things too, is that, you know, there's some approaches that maybe you don't take the full training, but there are preparation tools that I've trained some of my therapists on using. So even though they're not doing the desensitization and the bilateral stimulation, they can do still some preparation with their
Yep.
clients. and they're not out of their scope of practice and they're not doing anything unethical.
Right. And I use bilateral stimulation sometimes in my work. I'm not EMDR trained, but with kids, it might be just like tapping their shoulders or moving across the midline or something like that. So, like, it can be in bilateral stimulation is just a technique. It is not just, you don't have to be EMDR trained to do bilateral stimulation movements.
Correct, correct. So then phase 5 is the installation. So following desensitization, so once that target memory is no longer distressing, then we identify positive emotions and thoughts to replace the negative beliefs. And I know I'm going over this quick, but the goal is not to like be like we said at the beginning, not to be able to implement this today. This is just to understand it at a global level.
Right.
And then you always do a body scan. So we want to always be able to integrate this on a somatic level because we know cognitively someone can say, oh, I believe that I'm a good person. But then when we say, okay, when you think about being a good person and you scan your body, what comes up? If there's like angst or something, then we process that on a body level because the body and the mind can sometimes have different beliefs. And
Mm-hmm.
so we want to make sure that sure those are aligned.
And sometimes people are very up here, but not in their body, or very in their body and not up here. So you want to integrate those two.
Exactly. So then say phase 7 is closure. So each session ends with a therapist guiding in some mindfulness, grounding, or relaxation to ensure the client doesn't leave upset, right? So some sort of container or closure, even if maybe the desensitization hasn't fully finished, right? Sometimes, as a lot of us therapists know, we can't fully wrap up in that 55-minute session, and that's okay. And so then in the next session, we always reevaluate. So phase 8 is at the start of every new session, we're always monitoring progress. So regardless of if you're doing EMDR or not, we're really doing this as therapists all the time, is we're monitoring progress and deciding how to continue. So do we want to start a new memory? Do we need to work on the memory we were working on last time? Or do we actually need to go back to preparation because maybe the client we're working with is really triggered and it feels like, you know, it's important to work on coping skills before we go back into the trauma.
I have a so thank you for that very good overview of the 8 stages. Is the goal ever to get it down to be not distressing at all, or is it to lessen how distressing it is?
So there's different theories on that. So in the training, the goal is to get it to a 0, which is with that subjective unit of distress a 0. Um, I will say sometimes it's going to be a stuck at a 1 or a 2. And so you ask the client, tell me more about that, because sometimes a client's going to say, it's never going to be a 0 because, and then they're going to have a reason. And depending on that reason. And it could be, this is just inherently stressing and I feel good about being a 1 or I feel good about being a 2. Like, let's honor that. And it's okay. Like, we really want to take in what our client says rather than just saying, well, the model says it has to be 0.
0, so
Right. Yeah,
and that's just good therapy, right? Me and the client where they're at.
exactly.
Okay, that's helpful. So how do you as a clinician determine who might be a good candidate for this? Or what are some maybe signs or symptoms or experiences or events that would make someone a good candidate for EMDR?
Definitely. So, one of the main things is desire, willingness, readiness for this. And when I say that, is that some people are really scared of this treatment. They've maybe heard that Someone's had a bad reaction. So I once brought it up to a client and they said, "Oh my goodness, my friend had a really scary reaction. She had a panic attack after, and so I don't really want to do it." So, you know, of course, I'm going to meet my client where she's at. I'm going to provide her some psycho ed that of course anybody can have any reaction to a treatment. I feel terrible what happened to her friend and never pressure her into any treatment. So, for example, that would not be a good um,
Someone,
client, right? It doesn't mean that I may not bring it up to her in the future, and right, but so I think willingness, readiness is an important factor. Like I said, it's not just with PTSD, but there are modules for phobias, for eating disorders, for addiction. I would say getting consultation or specialized training in those is important and making sure that that's in your scope of practice.
and is there any contraindications where, obviously, if you're not ready or you're not willing, but is there anything that is a contraindication that maybe this is not the best treatment modality for you that you would discuss with the client?
Definitely. So, one of the main things is, are you not in a stable place in your life? So, for example, if someone's switching jobs or moving, or they're in a very unstable place in their life, th- or hey, I'm going to go travel for the next 2 months,
Yeah.
that this treatment requires consistency.
Okay.
So I really like to see, and everybody's really different on how clinicians like to see their clients, but clinically, I really recommend weekly for this treatment, and really monitoring clients. So every other week, I'm sometimes okay with based on the client, but I need a client to be really consistent and to have things pretty stable in their lives, not a lot of changes going on.
And so this is not someone that's like on maintenance, right? Like, I'm going to come once a month and get an EMDR session. It's not that type of modality.
Correct. I mean, there is a sort of maintenance after you've maybe done
Right.
EMDR, and then you might come back for a maintenance session. But if you're starting EMDR, that is
Right.
not a great modality for you. There are clinicians who are very skilled at working with dissociation, and dissociation can be people with dissociation and those symptomologies. It's not necessarily a rule out for EMDR. I would say you need a lot of training and skill set to do that with EMDR though. So again, not a like 100% a rule out or 100%
Right.
contraindication, but I guess the point is if someone's kind of, as you said earlier, not connected to the mind body, it's going to be very hard to implement this treatment. So that's why I really like somatic techniques to keep them present. And I think that's one of the hard parts about dissociation or psychosis. Um,
Yeah.
so I would seek a lot of consultation if that's kind of the population you're working with.
And then age wise too, I know within play therapy, there's some play therapists that do it. You specifically don't work with kids, but it can be used, it can be adapted to children as well.
Correct. And there are specific trainings for that. So,
Yeah.
yeah,
It's in the play therapy world, there's actually ways you can make EMDR playful. There's a whole it's the EMDR training, but focused on children and youth. So it's really cool stuff that is out there now to make it appropriate for whatever age that you are working with.
that is so cool. That's
Yeah. Um, okay. So you said some of, willingness, readiness. How do you start these conversations when you're like, I think someone would be a really great candidate? I'm sure some people seek you out. Hey, I've seen people like, I'm looking for EMDR. Maybe they're familiar, or maybe they are a consumer of mental health, or they're in the field. But then what if someone is like completely not aware of this and you're trying to say, hey, I think this would be a really great modality for us to engage in? How do you discuss that with them? How do you provide psychoeducation?
Yeah, great question. So typically, I like to link it with their values and their goals. So usually I'll bring up a new modality when it feels like a client is not reaching the goals that they're looking for in treatment. So for example, maybe a client is having, let's say, flashbacks or nightmares related to their PTSD, and the modalities that we've been trying aren't effective and or aren't effective as we'd like. And so I'll say, "Hey, I know we've been trying these modalities and we've gotten this far, but you know, I'm trained in this technique or I've heard of these techniques, and would you be willing to learn more about it?" And then
Got
I'll pause. And so the reason I'll pause there is because if I continue to kind of, you know, word vomit a bunch of information, I tend to lose them. And what I'm doing is asking for permission.
Mhm.
And
And
so
that's
then,
the important consent and explaining what this is. And I'm sure some might say, hey, I need some time to think about that. Or do you have more information you can present to me about it?
exactly, right? So I'll say, "Hey, have you heard of EMDR?" And a lot of people have, right? And
Right.
then I'll say, "What do you know?" So first I'll ask, "What do you know?" Because a lot of times people know something, and then I'm not repeating information that they already know, and then their eyes glaze over. Um, that,
Or
you know,
you're so high level because they don't have the basics and they're like, what did she just say? What bilateral stimulation? What is going on?
exactly. So yeah, so I'll first assess what they know, right? If they've given me permission to move forward, and some people are like, no, I like what we're doing, and then I'll say, okay, great, right? Or, right, and I'll just pause there. But if they want to continue, I'll say, what do you know about it? I'll assess what they know, and then I'll say, would you like to learn more? Each stage, I'm asking for permission, asking for consent. And so basically what I'll say is kind of what I said to you earlier. I give very kind of eighth grade, seventh grade level information. Some people love articles, so I will send articles. There are blogs on our website that we write for the general population for our clients. So I'll guide them to a couple blogs, and I'll also kind of show them in real time what bilateral stimulation is, because that does feel like a kind of a weird word. So I'll show them what eye movements are, I'll show them what tapping is, and I'll maybe give them an example of, oh, well, I know you mentioned that, for example, the car accident you were in, or like that's something we could work on specifically in this treatment.
Awesome. We touched on it a little bit at the beginning, but how do you incorporate cultural values or how is that integrated into EMDR or people from different backgrounds so that it is culturally appropriate?
Yeah, I think each training, depending on the facilitator, depending on the actual um, organization that leads the training within EMDRIA, um, does a different level of, you know, expertise, has a different level of expertise in how they incorporate this. So, I think when working with clients who everybody holds intersecting identities.
Right.
So everybody does, whether they bring that to the table as something that they want to work on that are visible is a different story. But I always approach therapy, what EMDR or not, with as much cultural humility and curiosity as I can, right? So I try not to make assumptions and create a space for the client to define what's important to them about their identity. So, trying to recognize how systemic oppression and marginalization can shape experiences of safety, trust. And that's why we spend so much time building safety at the beginning, building trust, and sometimes that means adjusting my language, adjusting my pace, like understanding where they're coming from. And that's that's really the the privilege that I get, is to understand each person's experience to the best of my ability, and not coming from like, oh, because you are this race, this gender, this sexuality, you must have this experience, and therefore this treatment is going to look like this for you.
That so basically the tenets of good practice, clinical practice, being culturally humble, being curious, owning your own privilege and biases goes into it the same way that it would for any good clinical work.
Exactly.
Okay, that's very, very helpful. Um, I have a couple more follow-up questions. I know everyone's journey is different, and you said it could be just like a quick modality for some people, but it for the most part, is this like maybe something that goes on for quite a while, or is that completely dependent on the person?
I'd say it's completely dependent. I will name that if you're coming in with a history of complex trauma, it's going to be longer, just as any other treatment is. And I think that's that's something that is a misconception, that that this treatment is kind of a quick fix, I think, for a lot of people. But when we have a history of complex trauma, that it's in the name, it's complex, right?
Okay.
And sometimes we're also in treatment and something happens, like a pandemic hits and something new comes along, right? So sometimes we think that, oh, what I'm coming for is really straightforward. And then once we come into treatment, we realize, oh, it's actually like really complex. So I just really encourage people that um, if you've been told that you should do EMDR, even if it's by somebody that you really trust, um, get an assessment. Go to somebody who's really trained in EMDR, trained or certified. It doesn't, either one works. And see what they say. Because, for example, I used to work in substance use, and the courts would tell us, make a recommendation about what a client, or what a client needed, but then they would come to us as the therapist and we'd say that's not really what they need.
Right.
So it's not that the person who recommended EMDR is has bad intent or malice. It's that we hear this treatment a lot, especially in Michigan, that it's, or in our society, that it's like a really good treatment, and it is. But again, one size never fits
Right.
all. And there might be a better treatment for you right now that the therapist either provides or knows about, because they've done a thorough assessment on you, where the person that's, saying, oh, you could benefit from EMDR, doesn't know you on the assessment level as this therapist does.
Right. It's similar to, I think every so often, like very buzzwordy treatments come forward. I remember there was a time every client that came to me, they said, my pediatrician or my doctor said I need CBT. So it's like, right, like, yes, you probably need some sort of treatment, but is CBT necessarily the right one for you? Maybe, maybe not. So I like that you've preferenced this, that like ask questions to a provider. It could be incredibly effective, but it's not necessarily needed for everyone, or the right time for that person to engage in that.
Yeah. Yeah, like sometimes we have to work on something else, right? Like if there's an eating disorder that's active or substance use that's active, sometimes we have to work on that first, not always, before we go into EMDR. So that person that recommended that might not know that first, right? So
Right,
again,
right.
they're not saying that out of malice, they're just saying that out of lack of full knowledge of what's going on.
And like you said, you want stability for that person. So if someone goes into crisis, you're going to need to work on the crisis management and stabilization before you're like hopping into this type of modality.
Exactly.
Okay. One more question to tie it into your other work that you do. I know you said that this is like, to me, I'm the same way. I'm very prescriptive. There's layers to what I do and different modalities. I'm always weaving in and out. Um, how does this tie in? How does it complement? How does it add to your somatic work and your IFS work?
Yeah. So, like I mentioned, not only in the preparation phase do I use IFS, somatic, even CBT, DBT, right? But in the other phases, I refer back because sometimes what happens in the desensitization or other, even in the body scan, right, is that people can get stuck, right? So we're um, desensitizing, going back and forth with the eye movements or the tapping. And what what we'll ask is, what do you notice now? Or that's pretty much the question we ask over and over again. And so we're just asking for a little prompt of like what's going on inside. And so sometimes dissociation can come up, or sometimes a cognitive distortion can come up, or sometimes a part can come through. And so that's when I can use all these other tools in my toolbox to say, okay, yeah, notice that that part, that angry part's coming through. Can we ask it to step back? Or, okay, maybe some dissociation is coming up. We maybe have tools for dissociation that we've used, and we can refer to those. So, um, that's why I like to have so many tools in my toolbox because everybody benefits from different um, coping skills and strategies, and each modality has such amazing attributes.
Mm-hmm. That's really helpful. And just like a reminder to clinicians out there, you probably were the same when we first got out of school. I felt like when I first got out of school, I was like, I am going to be like a CBT clinician. But then the more you are in the field and the more I always say this, the more longer I'm in the field, the more you realize you don't know or where there's holes or you need to get training. So this is just one of those things that like this is a modality. It's not the end all be all, similar to any modality, right? So it is an extra added awesome evidence based, and this might be someone's specialty, right? They might like mostly focus on EMDR, but like you had said, it adds, it helps you really be holistic in your approach.
Exactly. Yeah. And it's great to niche because then you can kind of hone in on one thing, but it's also great to know, hey, I'm gonna expand here and also know that I took this training and I don't really like that. And that's okay too.
Yeah. Is um is this a very high fidelity training that you have to follow it with fidelity? Obviously there's the 8 phases, but is there, I know you said sometimes it can ebb and flow, but is it something that you can go in and out of the phases, or is it you have to really approach it by the book?
Yeah, so there's because it's evidence-based, of course, you want to approach it relatively by the book, but there is ebb and flow to it, right? So you're not necessarily like holding a book to your face and reading a script. I think when you start, it can feel that way because we, as most therapists, I guess I'll speak for myself, I want to get it right. I want to treat my clients
Right.
well. I want them to get the results
And
they
you're learning, right? You're like, I want
right.
to make sure that I'm doing it correctly.
Exactly, right? But there is room for flexibility, there is room for growth, and because there's so many different types of training, like if you go on the website, there's different trainings, how to incorporate it with somatic work, with IFS. Um, I mean, just with so many different modalities, it's really cool to see how they morph it. So we want the integrity of the 8 phases, but you can really integrate your own dance and your own clinical expertise within that.
Just like any modality, it takes, seasoning. Someone
Right.
said it's like a recipe, right? Like
Mm.
you could do it just by the book, but it's not as exciting or interesting as if you add a little bit of your own twist to it.
Correct. I love that.
Okay. Mom, to wrap up, so thank you for this broad overview. So I'm gonna send out the EMDRIA site, so that people can get involved there. Do you think this is a treatment that people, like you said, most people are aware of it, but who would be someone that would be a good candidate to get maybe the further experience training in it?
Yeah, I think clinicians who are very interested in in-depth trauma training, right? So if you're a clinician who are like, I like treating patients with trauma, but it's not my bread and butter, I wouldn't really get this training. This is an in-depth training, and it requires a lot of
Knowledge.
reading, right? A lot of consultation. And if
Commitment,
clients are,
really.
yeah, and if clients are coming to you, they really want it. They're very interested in getting this modality, and they, at least in Michigan, what we're seeing is they have a lot of complexity.
Mm.
And so I would say if you're very interested in trauma as kind of one of your niches,
Yes.
this is a good
I
training.
love that you said that because I think too, like trauma informed practice has been like such a big movement in the past, I don't know, maybe 5 to 10 years. And I say all good therapy, all good treatment is trauma informed, but and people are like, are you a trauma therapist? I can deal with people that have experienced trauma, but I do not specialize in trauma. I would refer out. I have dealt with cases that have, of course, everyone has had some level of trauma, but like you said, it's someone that like this is what your area is, that most of your clientele has this background and you're really seeking the expertise in this area.
Exactly. Like, for example, eating disorders, right? Like, I don't have training expertise in eating disorders. Will I turn away a client who has eating disordered behavior? Absolutely not. But if that's their primary thing that they want to work on, they're saying, I'm coming in because I have anorexia nervosa and that's my primary presenting problem. I'll say, that is not my scope of practice. Like, I'm not going to be, that's really unethical. It's not going to fit for us, right? And that would be kind of similar for this, right? If you're saying, but like to say people are going to come in without trauma, like
Exactly. We
that's
have to
not
have
going to
the
happen.
trauma informed care is the baseline. This is like when you're wanting to take it further.
Exactly. Exactly.
I love that because I do think that we throw around the word trauma informed, but that's to me, we have to be like, that's the baseline. You can't do any sort of work that is of benefit without being at least trauma informed.
Right. And this is not a trauma informed training. This is a trauma
Exactly.
treatment
This
training.
is a trauma evidence-based modality.
Correct.
I'm glad that because sometimes I think people get conflate the two.
100%. Right. So if you're looking for more of like a trauma informed training, those would probably be like a couple hours
Right.
long, like 1 or 2, 3 or 4 hours long, not multi day.
Yes. And that's always when I say, like, when people, you might see these trainings get trained in 5 hours, like, always just be doing your research, right? That might be a CEU topic, but that does not mean that you would be certified or trained. There is a big difference. So I'm glad that you were able to. Are a lot of misconceptions out there and myths. So I'm glad that you were able to give us a broad overview of EMDR and what are some of those myths, misconceptions. Any last points that you think are important before we wrap up?
I think the one last thing I'll say is PESI is a resource that a lot of people use for trainings, and I think it's a really great and accessible resource out there. But if you're finding an EMDR training on there, make sure that it is through EMDRIA, because a lot of people have reached out to me to work at Embodied Wellness and they've taken the PESI training thinking that they are now EMDR basic trained, and they're not.
You
So
have some good knowledge now, but it is not official.
Right, it's not the official training. So they've taken a 2-day or a 3-day training through PESI. And so I just feel terrible, right? They've spent this money and this time. And so I think there's a lot of misinformation out there.
Yeah. And I, once again, will just reiterate this point. Always like, it's okay to ask questions if you're like feeling a little bit unsure. If it seems too good to be true, it probably is. So just ask questions. And this is when you really want to use your, if you're just starting on the field, talk to your clinical supervisors. If you have already been in the field, ask your colleagues that you trust. And don't believe everything you believe online, right? Like there could be fake accounts or who knows, right? You want to just make sure that you are getting the highest quality um, educational access as possible. So thank you for that, Sarah. That's always important stuff. We have here some just research articles, some scholarly articles that are new in the past like 2 to 3 years. EMDR is not new, but I would say it's newer in the field. And more and more and more research is coming out because if they're longitudinal studies, like we've had more years of clinicians have had more year and researchers have had more years of experience to put out some really cool stuff. So check it out. And I want to just wrap up by thanking Sarah. She always does such a great job of really helping us understand maybe these more complex topics and modalities and breaking it down into easy to understand. I learned a lot. I am not trained in EMDR. I am very elementary level knowledgeable about EMDR. So I learned a lot in this too. So thank you, Sarah.
Thank you. Excited to be here. Glad to help.
Yeah. And for CEs, you will have to take your learning quiz and your evaluation after this to make sure that you are getting your credits. And remember, we are certified for social work, ACE credits, and NBCC counselor credits. So make sure that if you are doing this for your CEs, you complete your eval and your test so you can get your credits. So thank you. And I hope that you enjoyed our EMDR deep dive. Thanks. I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.